Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi, my name is Mike Sullivan. I'm one of the instructors at Valor Medical Services. In today's presentation, we'll be discussing pediatric patient assessment. Now, this is the first in our series of pediatric patient care videos, and hopefully you'll find these both interesting and informative. In this video, we're going to be discussing anatomical and physiological differences between our adult and our pediatric patients. We're going to compare the phases of pediatric assessment. We're going to talk about conducting a thorough assessment of pediatric patients and develop ways to modify our conventional assessment to overcome the challenges posed by pediatric patients. Now, studies have shown that EMS providers typically transport or respond to 10% or less pediatric calls. I know where I did statistics for one point, we had 5% or less each year that were 12 and under. So as a result of that, what do we see? There are some significant differences with peds, and one of the biggest ones is we as providers don't see them a lot, and so therefore we're not always 100% comfortable with them. One of the goals of this presentation is to get providers more familiar and more comfortable with responding to pediatric emergencies. Now, some of the key differences we're going to talk about. Infants and children are not just miniature adults. While there are some similarities, there are a few key differences, and we're going to talk about those. We're going to divide these into anatomical differences, which are different structures, different size structures, physiological differences, which is differences in how the child's body functions and behaves, and cognitive or mental differences, differences in how they think or how they process information. We as providers need to take all of these into account as we begin assessing and treating pediatric patients. Now, some of the big differences, first in anatomy, pediatric patients have a very large surface area to weight ratio. What that means is they're not basically as well insulated as adults are. Because they have this large surface area, they can lose heat more readily. They can be more susceptible to hypothermia, more susceptible to evaporative cooling. And again, their core is not going to be as well insulated as ours is. This being said, we need to be conscious anytime we're dealing with cool weather, not even cold. I'm not talking snowstorms. I'm talking 50, 60 degree weather. Remember, the child's core temperature is trying to maintain 98.6, so therefore, anything under 98.6, they can be losing heat, and they will lose heat more quickly than an adult will. Some other differences when we get into physiology. Pediatric patients are going to have less of a physiological storage or reserve than their adult counterparts. This makes them more prone to hypoxemia, more prone to hypoglycemia, and more prone to hypovolemia. If we think about it, they don't have as much fluid, so again, minor fluid loss for them would be a much larger percentage of their overall than it would be for you or I. Additionally, due to the fact that their intercostal muscles and their chest wall muscles are not as well developed as ours are, they're much more likely to wear out faster from the excess work of breathing. Think about their smaller muscle groups are going to tire faster than ours will. Therefore, excess work of breathing in a child can be a very ominous sign because they'll tire quickly. Also, children are likely to compensate far more effectively than adults. However, they fail and decompensate far more suddenly and far more dramatically. When you sense a child is compensating or you believe they're compensating for something, we need to address it aggressively to be out in front of it so that way we can prevent that failure or decompensation from ever occurring. Now, when we get into specifics such as airway management, we know that pediatric patients are going to have smaller and far less developed airways. Thus, it's much more easily occluded, whether by a foreign body obstruction or by mucus. Think about the smaller airway. It takes a lot less mucus or a lot less foreign body airway obstruction or a lot less foreign material to occlude their airway. Additionally, because it's smaller and less developed, it's much more easily crimped or damaged. Think about the comparison between trying to crimp off a garden hose versus trying to crimp off a fire hose. Well, the fire hose is going to be much more rigid. It's going to be much more sturdy. Therefore, it's going to be harder for something to damage it or crimp it. Whereas a thin wall, very weak garden hose, it can take very little pressure just in your hand to crimp it. This being said, we know the tongue is also much larger in proportion to the oropharynx, takes up much more room in the oropharynx. Therefore, their tongue is almost as if it's already partially swollen. So if they are involved in an allergic reaction or something similar to that, if their tongue starts swelling, it can swell very little and still cause significant airway problems. Another key anatomical difference that focuses into airway management, the prominence of the back of the patient's head, the occipital bone, tends to tilt the head forward when placed on flat ground. If this head is tilted forward, it can actually crimp or possibly occlude up to 40% of the airway. Ideally, if we're laying the patient on something flat, such as a backboard or a mobilization device or even an exam table, if we pad under the shoulders, whether with a folded towel or a blanket, we can lift the shoulders slightly and thus maintain neutral inline position where the patient will have a more open airway, less airway occlusion. Again, if we lose 40% of the airway to an occlusion, it will exacerbate any mucus obstruction, it will exacerbate any foreign body obstruction. This would make it a lot easier to keep the airway open and have 100% of your airway ability there. So now let's look at some differences in some of the age groups and how they respond mentally and cognitively to us. Now, when we look at different age groups, we'll start with the infant. They're up to 1 year of age. Typically, the only method they communicate with is crying or screaming or screeching. They may begin to adapt somewhat to their surroundings as they get a little bit further on up in age, but generally, they can't communicate. They can't tell you what hurts, where it hurts, or why it hurts. They just know something's hurting them, and that's about all they're communicating is they're upset about something. It could be that they're hungry, it could be that they're constipated, it could be that they need to poop, or it could be that a wasp stung them and we don't know about it. Now, a toddler, 1 to 2 years of age, they can begin to learn to speak and express themselves. However, they may not be able to still express themselves well or give a real good history of anything that happened, but they may be able to point to where it hurts or give you a little bit more of a clue, a little bit more of an idea. Preschoolers between 3 and 5, they begin to get more and more vocal and actually more expressive, and they can tell you a little bit more. They may be able to tell you what happened, or at least give you some hint about what's going on. And again, the more we can find out from them, the more it can help with our assessment and our management. Now, by the time we get up to school-age children, that's about 6 to 12 years of age, vital signs begin to normalize. They begin to develop some degree of self-esteem, body image sensation. They begin having reproductive development on the later end of that scale. These children are aware of, more. They may be very concerned with permanent injuries or scarring or being disfigured or things like that. And again, begin to become a little bit more self-conscious. Now, adolescents from up to 13 to 18, they're going to complete their reproductive development. They'll also be somewhat more self-conscious and definitely socially conscious, maybe very conscious of being embarrassed about something going on. They may try to hide certain things from you. They may be engaged in different types of self-destructive or dangerous behavior. We all know, especially in that age group, kids tend to feel that they're immortal. Nothing can happen. They'll take high risks. They may be climbers or jumpers, especially adolescent males. I was a teenage boy at one point, and we were climbing trees and daring each other to take bicycles off of shed roofs or different things like that, or different jumps on dirt bikes or things. So again, we'll have a little bit more, exploration, a little bit more independence, but with that independence definitely comes pushing of boundaries. And so it may indicate or may end up with some more interesting injuries. Now, as we get into looks at vital signs, this chart was brought out of the emergency care textbook, the paramedic textbook, 8th edition, and it's a really great comprehensive set of vital signs. I will stress, however, very much so, that don't be so much brought into what the specific numbers are. Ideally, we know we can memorize the numbers, or you can have a cheat sheet for numbers with you, or you can look them up on some portable device to reference correct numbers. We know that 12 to 15 years of age, we'll see pretty close to what you'd see with an adult. About 110 systolic could be a low end of normal BP, 12 to 20 respiration, 60 to 100 heart rate, pretty consistent with what you'd see of the average adult. When you get all the way down to under 1 year, we see that the BP is significantly lower, but the heart rate and respirations are significantly faster. Now, if you've got, say, a 2-year-old who has a respiratory rate of 24, and we say, well, that's in the normal range. However, if they're not moving good air, or they're struggling to breathe, or they're blue, that number 24 means very little. Deal with more their presentation or their work of breathing. Much in the same way as just because their blood pressure looks good numerically, are they compensating? A lot of times, numbers are great and they look great on reports, but the characteristics and everything surrounding it will tell you a lot more. So, general rule of thumb, the younger patients will always have faster heart and respiratory rates. They'll typically burn through oxygen more quickly. Their systems are working harder. They work at a higher energy level, and they'll typically have a lower blood pressure than the adults. But as it says on the bottom there, numbers can be very deceptive. Your presentation will be a far better indicator of the patient condition and patient status. So just because numbers are good, a respiratory rate is not adequate if the patient is showing signs of respiratory failure. A heart rate is inadequate if patient is showing sign of poor peripheral perfusion. A blood pressure is not adequate if patient is showing signs of compensating. Any of these, again, be more gauged to the presentation of the patient and work towards achieving a good presentation than achieving numbers that are on a prescribed chart. Now, as we approach these children, we need to take into account the differences in their mentation and their cognition as we begin to assess them. As we delve into assessment, a few things we want to think about. First off, and a big one to remember, Any EMS response to a child is going to be particularly worrisome for children as well as the caregivers. What is a normal day at the office to us and a normal response to us? Yeah, we may get a little bit antsy because it's a kid call, and we know that. We also need to realize that this mom or dad or caregiver or grandma or grandpa or stepmama, whoever it is, has just had to call 911 for their baby. They are going to be extremely ramped up. So once we come in and we make our initial evaluation, we may want to slow our approach down to avoid overwhelming them. A lot of times this can pay big dividends. If we can take the edge off of the response, we can actually calm them down and get a whole lot further with them and stop some of their panicking. Again, for us, having an ambulance riding around is a very normal thing. For them, having an ambulance show up in their yard, particularly if we're responding with a full box with possibly fire, EMS, or a QRV with us, all these strange vehicles are showing up, lights and siren, they've just called 911. It's the absolute worst day of their life. Now, if the parents are all worked up and worried, or the caregivers are all worked up and worried, who's the child going to take the cue from? The parents or the caregivers. So now they're all upset. And a lot of times what we can do is we say, okay, we've got our general impression, and once we realize our general impression is the child is relatively stable, we can slow down a little bit and not only put the parents at ease, but that will help put the child at ease. And doing all that is going to be beneficial not only to our assessment, but to whatever's going on with the child as well. So again, be guided by this. As we approach the patient, we can begin to develop our general impression. This is the first step of our triage. This can be done with no equipment, and a lot of times it can be done from 5 feet away as we enter the room. It should set the tone for the remainder of the encounter. Think about it. We know what a normal child looks like or acts like. Is this it? When we walk in, we should get a general impression. Is the child sick or not sick? And when we say not sick, we don't mean they're not sick at all, but they're not critical. Okay, this child may have an ear infection. They may have strep throat. They may have pneumonia or something like that. But if the child overall is presenting fairly normally, we can relax a little bit and say, this isn't going to be a bad one. And on the other side of the coin, by slowing down and taking our time, we can actually help stabilize the situation a lot. Remember, parents and caregivers are going to be very overwhelmed at the point they're calling 911 for us for the most part. Now, when we're putting together this presentation, one of the people in our office brought a child by, and we got a quick picture. So if we're walking in across the room and we see this child, what do we think is going on? Does this child look sick or not sick? You know, my doorway diagnosis or my eyeball across the room, this child looks fine. They're alert, they're active, they're clearly awake and responsive. They're actually, at the time I snapped this picture, he was looking up on the screen. I flipped on my webcam, and he was very fascinated with the fact that his picture was coming up on the computer screen. This child would definitely fit the not sick category. So, okay, what all goes into our general impression? Well, first off, the appearance, the mentation. Are they responding appropriately? Do they acknowledge you entering in the room? Do they even look at you? Think about it. 1, 2, 3 strange people just walked into the house, walked into the living room, or walked into the child's bedroom. If they don't even look up and acknowledge you, very ominous sign. If they look up and they talk to you, very good sign. Look at their muscle tone. Are they sitting up? Are they conversing? Are they active? Or are they limp and lifeless? Look at their positioning. Are they slumped over? Are they tripod position? Take a quick look at their breathing. Do we hear them breathing across the room? Do we hear sounds, noise? If we look at their neck, do we see retractions? Do we see sternal retractions? Is their head bobbing, trying to stay awake? Do we see nasal flaring, seesaw breathing? All of that would be signs of breathing issues. Look at their position. Are they in a sniffing position? Are they in a tripod position, struggling to get air? Or are they sitting very comfortably, very normally? Circulation. Do they look normal skin color? Are they very pale? Do we see mottling on the extremities? Do we see cyanosis around the lips and mouth? When we touch their skin, look at their skin condition. Do we see any visible bleeding, any wounds, any puddles of blood, or blood-soaked clothing? All of this can be our general impression, and we're getting a very, very rapid assessment. Now, if we go back to the last picture here, I can definitely say if I was walking in to deal with a pediatric call and this was the child I was dealing with, okay, we can definitely relax, be calm, no reason to worry about it because everything seems to be relatively stable with this child. On the other side, if the child is slumped over, barely responsive, we know it's going to be a lot more serious and we may need to hurry a little bit more. Now, as we initiate our primary survey, we're trying to deal with immediate life threats. The whole gear of the primary survey is we're going to focus on airway, breathing, and circulation, quickly assess them, and any life threats we find are managed with simple, rapid interventions as they're detected. First phase is we'll lock level of consciousness and responsiveness. Are they alert, responding only to verbal or painful stimuli, or are they unresponsive? When we evaluate their airway, is it clear? Are they able to maintain it? Or do we hear sounds such as gurgling or stridor? If we hear gurgling or stridor, we may need to try to either position them more effectively. If there's secretions in the airway, we may try to suction it, either with a powered suction or with a little one. We can possibly use even a bulb suction to try to get some of the gunk out of their mouth, even maybe out of their nose. We can perform manual interventions such as a head tilt, or if we suspect C-spine injury, we could use a jaw thrust, and we may even want to go ahead and look at inserting an oral or nasal airway. And in some cases, if the child doesn't have an airway at all or is unable to maintain, is unresponsive, we may even look at a blind insertion airway device. All of these are options based on what we're assessing with the airway. Now, as we look at their breathing, how hard are they working to breathe? Are we seeing a lot of effort of breathing? Are they struggling? Do they appear like they're tiring out? Look at their respiratory volume. Are they moving good air? Again, when we listen to their breath sounds, do we hear a lot of gunk and a lot of junk in their lungs that we know is taking up tidal volume space? Look at the rate and the rhythm of breathing. And again, while the rate may tell us a little bit about the numbers, we can tell if they're slowing down, if they're speeding up. Does it seem irregular or is it regular? What's their pulse ox? And again, we look at the pulse ox, it gives us a number, and while numbers are not always great, at least if we have a number of what's going on, we can measure that as we begin different interventions. If we can do end-tidal CO2, that's great to do also. Ideally, again, we should have some idea, is their breathing effective, ineffective, is it something I can help with it? Now, some of our respiratory or breathing interventions, we can go ahead and put the child on oxygen. We may use a little bit of blow-by oxygen, or if it's more significant than that, we may have to use an oxygen mask if they'll tolerate it. We can initiate mouth-to-mask breathing, or may even use a bag valve mask with supplemental oxygen. A lot of it depends, again, on what their presentation is showing. Moving onward to the primary survey, we get to circulation. Now, as we look at circulation, we want to compare the central versus peripheral pulses. Do we have only central pulses and no peripheral pulses? Do we have them both? Are they both equal? Do we tell that the central pulse is good and the peripheral pulse very thready and weak? Again, we may not have a number, but I can tell you good perfusion when I feel it. Look at the heart rate and rhythm. And again, when I say rate and rhythm, it doesn't mean we've gotten to EKG yet. It just means, is the heart rate appropriate or fairly appropriate for the age group? Is it nice and strong and regular? Look at the skin signs and the skin color, the temperature, the moisture. What does it feel like? If the patient is cool and clammy with mottled skin, that's signs of shock. If the patient is pink, warm, and dry, that would be normal. Are they hot and red, possibly indicating a fever or sepsis of some type? Again, we can learn a lot just by doing the basic assessment. Looking at the capillary refill. Now, in adults, I know we typically pinch the nail bed. On adolescents, we'll do probably the same. On infant or child, you may use your thumb against the base of the foot or against the underside of the foot. Again, delayed capillary refill would be a sign of poor perfusion. Now, some of our interventions for a circulation issue, we can try positioning the child better. If there's no pulse at all, we may start with compressions or an AED. We may start with fluid management, fluid resuscitation if the child is possibly dehydrated or hypovolemic. Going through the next stage, we'll look at disability. Now, disability gets into level of consciousness. How responsive are they? Can we get a Glasgow Coma score or a PEDS GCS? Typically, it's going to be a 3 to 15 scale, and we rate them based on eye-opening, verbal response, motor response. Are the pupils equal? Are they reactive? Are they sluggish to react? Now, the scale shown in this category is the adult. We can also modify that for younger children who aren't verbal, where we can have a verbal response there, whether it's grunting, crying, or screaming. They get graded on each one of those, and again, it's a 3 to 15 scale. This can give us a good, easily comparable to how awake they are initially versus how well they're doing after multiple interventions. When we get into the E is exposure. Now, the secondary survey, we do a rapid assessment. We also want to look at bites and stings. Is there a rash, injuries or bruising, any wounds we see? Again, typically 2 and under, they may not be able to tell us that a wasp or a hornet bit them or an ant bit them on the foot. And we may not know why they're having trouble breathing or why they're having the rash, but that may show out to why. It may give us a clue of why they're crying, why they're upset. Again, we have to sort of balance this with the temperature and the environment. We don't want to overly expose them in a cool environment and have them lose body heat. But on the other side of the coin, we do want to do a pretty good assessment. Now, as we come out of this, we should have some ideas of how critical or sick or not sick the child is. If the child is extremely sick, chances are we've already either started making our way to the truck or we're already in the truck. On the other side, if they're not sick and they're relatively stable and it's relatively minor, we can slow down and take our time on scene. Now, when we look at the secondary survey, it's made up of 3 key parts, and many times this is accomplished concurrently with one another. We'll have our focus history, also known as our OPQRST history. We want to get sample history, or in some children we'll use CIM-PEDS, and we'll talk about that later. And again, a head-to-toe examination. Now, our focus history, or OPQRST, is based on the illness or injury that we were called there for. So basically, we know what's going on. Well, the child is not feeling well. Really, when did this start? What was the onset of it? Is there anything that's made it worse or better, provoked it or palliated? What's the quality of the pain or discomfort? Can you point to where it hurts, the region, or does it radiate anywhere? And again, the severity of it. If it hurts, can we get the child to give us a 1 to 10 scale? Now, if we've got a 3-year-old, we may be able to get very little of this. If we've got a 10-year-old, we may be able to get a lot of this. Again, a lot of it is going to be gauged based on the maturity of the child, and sometimes we may have to get history from the parents or other caregivers on scene. The next stage we want to get as much of as possible is the sample history. Now, we use sample on most of the adult calls, most of the general calls we go on, and we know it's signs and symptoms, allergies, medications, past medical history or pertinent past medical history, last oral intake, and the events leading up to the call. And that is acceptable in a child. However, if you're dealing with an infant, the Emergency Nurse Association came up with the acronym CIM-PEDS, and it changes just a little bit and adds a couple of things in there. Chief complaint. Immunizations, are they up to date on all their shots? Allergies. Medications. Past medical history, those are all straight out of sample. Events, that's pretty much straight out of sample. And then the big one down there, diet or diapers. Why would that be a big deal? Well, if a child is dehydrated or hypovolemic at any level, they're going to have less urine and fecal output. So if mom and dad say, well, normally the child goes through, 3 diapers by this time in the day, and yet today they haven't had to change them once, what would that tell us about the child's fluid level and how well they're perfusing their kidneys? It would almost be an indicator right off the top that, well, okay, the child's hypovolemic and they're shunting from their kidneys, and that would be a sign that we're already in compensation, and so we need to be aware of all that. And it could be something very innocuous, like a stomach virus or something going around, or just overheated, summer, just not drinking enough fluid, not enough fluid intake. Anything like that can definitely cause a problem where the decrease in diaper use would actually indicate something going on. And lastly, signs and symptoms. So CIMPs, again, it's a lot straight out of sample, but on the other side of that coin, it also includes that diet and diapers, which to me is a big push. And the immunizations isn't bad to have in there, but the diet and diapers, I want to know how well they're perfusing, because that tells me a lot. Now, as we get into the head-to-toe exam, our general purpose is to evaluate the patient as thoroughly as possible and ensure that no injuries, conditions, wounds are missed. Now, we think about this, especially it's important with the very young. Again, 2 years and under, they may not be able to tell us what's wrong or why, and so therefore we may have to do more searching and more looking and examining to try to find out what's going on or figure out what's going on than you would with, say, a 10-year-old who can tell you that they got bitten or stung on the foot or the back or sat on something that's sharp or that has burned them. We may not know with a little child, but with this child, again, we have to figure it out. Now, our approach to this can be affected by various factors. Number one, the severity of the child's injury or condition. If a child is blue or limp or lifeless, we may not be able to have a lot of time to do a secondary exam. We may be headed for the truck or already en route and try to do as much as we can on the way. The child's temperament or demeanor. How cooperative are they with the exam? Are they going to allow us to do it or not? The child's developmental level. We may have to explain a lot of things with them and try to work through, trying to get them, can I look at your arm? Can I look at your leg? Can you point to where it hurts? A lot of times, again, with the younger children, they may have to have a lot of coaxing to get through the exam. Otherwise, they're going to try to be a little bit more difficult or less cooperative, so to speak, with it. The last one is the child's degree of anxiety with the providers. And this is a big one. Earlier when I mentioned once we come in and we realize that the child is not critically ill, not severely sick, we can slow down. I know sometimes we'll actually have a teddy bear or something on the truck that we can give them. In some cases, we may even have to perform part of the exam on the teddy bear and show them what we're doing before we actually do it to them. We may take and listen to the teddy bear's breathing with our stethoscope, and then we show them the stethoscope didn't hurt the teddy bear at all, so it won't hurt them. We may want to check the teddy bear's pulse, and that way we can show them that when we check the teddy bear's pulse, the teddy bear was fine with it, so then they let us check their pulse. Again, a lot of times, trying to decrease their degree of anxiety will get a lot more cooperation. Ideally, again, we shouldn't have to always do it, but depending on the age of the child and how scared they are, can definitely make our life a lot easier. Some things to consider as we approach it. How can we decrease this physical and emotional stress? Again, I mentioned teddy bears. I mentioned if the child has a pet in the house. I know personally, I've always been a dog person. So once I realize that the child is not that sick, I'll ask them about the dog. I'll ask them if I can pet their dog. And once the dog is okay with me, well, then maybe the child will be a little bit more okay with me. We also may be able to complete much of the assessment visually with the child on the caregiver's lap. We can have them wiggle their hands and wiggle their toes for us without us actually touching them. Can we demonstrate it on someone else or a stuffed animal? Can we slide the pulse ox probe? Can we say, well, look, I'll slide it on Mom's finger first, and Mom was okay with it. So now can I slide this on your finger? And again, working through. On the other side of that coin, is this sometime we should defer the exam? Do we have, possible epiglottitis and we don't want to do anything to upset them? Do we have a child who's having severe respiratory distress and they're not really able to do much of anything? One rule of thumb is if a child is very willing and compliant, and I won't say simple, but if it's very, very easy to get vital signs in an exam on a young child and they're not fighting you at all, that can be an ominous sign in and of itself. So then we'll start our head-to-toe exam. Now, when we look at the head, look for bruising or swelling injuries. Infants, if we have a year or less, look at the fontanelles. Typically, swollen fontanelles may indicate increased intracranial pressure. Palpate gently around the head to see for any tenderness or any signs of injury. If you see any open wounds, dress those and address those as we find them. As we look at the face, palpate the facial bones. Look for stability or deformity. Look in the nose or mouth for any injuries, drainage, burns, something that may indicate possibly the child has eaten or drank something that's corrosive. That would give us a clue to what's going on. As we look at the eyes, compare the size and shape and the movement of the eyes. Look at the color of the sclera of the eyes. Compare the equality and reactivity of the pupils. That again would be another sign of possible intracranial pressure injuries, things such as that. Look for any discharge from the eyes. Is there bruising around the eyes or paraorbital ecchymosis? Those would all indicate different injuries. Ask the child to open or close their eyes. Evaluate their reflexes. Look for any foreign body or scratches in the eyes. That can tell us something as far as why the child is crying and upset. Again, a lot of this with younger children, they won't be able to say that I scratched my eye with something or a bug flew in my eye and I scratched it. We'll have to look and find. As we look at the ears, look for any injuries to the ear itself. Look for any drainage, whether it be blood or clear fluids. Look for foreign bodies, something that may have been stuck in the child's ear. Observe the child to see if they're grabbing or tugging at their ear. That may indicate possibly an ear infection. As you feel the outside of the ear, is one ear specifically warmer than the other one? That would also be a very good indication of an ear infection. As we look at the throat and the neck, look for redness or injuries. Palpate the posterior of the neck for deformity or any point tenderness, any response as we palpate down. Does the child's neck appear stiff, or are they saying they can move it just fine? Where's the trachea? Is it midline? Jugular veins, are they distended? Do they have any signs of difficulty swallowing? Are they drooling? Now, drooling can be very normal in a very young child, but if the child is 2 or 3 years of age, we shouldn't be seeing copious drooling. Look for accessory muscles used or tugging. Look for any strange odors that are present from the mouth. Again, possibly there's something they ingested. Now, as we move down, we look at the chest or the thorax. We can look for bruising or swelling, injuries, rashes, things like that. We can also look for equal motion bilaterally. Is the child's chest expanding equally? Do we see any substernal retractions or retractions along the bottom of the rib cage when they're breathing? Are the breath sounds clear and equal? We can typically listen both anterior or posteriorly, and again, are they moving good air? Are they moving good air on both sides? When we look at the abdomen, we want to palpate for any tenderness or rigidity or masses. Again, we know what a normal child's belly should look like. Is this normal? Coming down, we'll look at the hips and the pelvis and the extremities. Is the pelvis stable? Are they moving all of their extremities, or are they guarding or favoring one of the extremities? Can they move all their extremities with purpose? Can we get them to grab your finger? If we tickle their toes, are they withdrawing from it? Do we notice symmetry among the extremities, or is there a deformity or something different there? Capillary refill, again, we can evaluate based on pinching the underside of the foot or pushing our thumb to the underside of the foot. Look at the skin color and temperature. Are pulses equal in all 4 extremities? This, again, would indicate possibly decreased perfusion. Vital signs may be evaluated, and again, a lot of times, if you can get an adequate blood pressure on a 3 or 4-year-old, you've done a miracle, or the child is very, very ill. For the most part, a blood pressure may be one of the hardest things for us to get. We may be able to get a pulse rate, may have to use our monitor to do it, may have respiratory count, O2 saturation. If we get an end-tidal CO2, great, blood sugar, and possibly EKG. Again, sometimes, depending on the child's heart rate, if it's extremely elevated, we may be able to get a more adequate heart rate off of a monitor than we can off of a manual pulse count. And again, a child lets you take their blood pressure, they're like 3 or 4 years old, you kind of wonder. Now, we should reevaluate and reassess about every 5, maybe 15 minutes, depending on the acuity of the patient. If the child is extremely acute, we should be doing almost continuous reassessments. But one of the most important parts of our reassessment is not only what's changed, but is my treatment working or not working? Did I miss anything in my last assessment? Possibly an area the child wouldn't let us get to very effectively. We may be able to start our reassessment there and find out a little bit more. A lot of times our reevaluation and our reassessment can be more important than our initial assessment, because not only will it indicate things we've missed, it also lets us know how well our treatment is working, and are we being effective? Do we need to change gears? Is there something else we need to do or do better? Now we repeat the initial assessment, we can repeat the focus physical, we can repeat the head-to-toe exam, we may repeat vital signs and recheck the status of any interventions. If we put the child on oxygen, is the oxygen still working? Cylinder good? Mask still in place? Is the blow-by still working? If we've started an IV, is the IV still flowing good? If we've started an IO, same thing. Again, going back through everything that we've done, is it working? Is it not working? Can we improve it? Alrighty, well, as we close out, again, I'm coming back to, calls for PEDS patients are a very small number of EMS responses. That's going to lead to increased anxiety. Face it, we don't do it that often. We're not that comfortable with it. It's not just another day at the office when you get a call for a baby unresponsive. We should be aware of some of the differences, how to address them when caring for the child, and in many cases, assessing a child requires providers to rely more of their skills of observation than report from the patients. This can be extremely true when you're dealing with the youngest group. They can't tell you that their ear hurts or that they've been stung by something or that they drank such and such. We have to sort of figure it out and be sniffing out for clues on our own. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.